general population. It's not uncommon with any of these diagnoses, or with any diagnosis you're treating in your practice, that you will see someone who has more than one diagnosis. You know, just because you've got diabetes doesn't mean you can't have heart disease due to inherited factors, right? Okay, so we've got sicklers, we have von Willebrand's disease, I've got hemophilia patients with platelet disorders. I mean, common things are common. It's not from going to camp together with other bleeding disorder patients, because we have those discussions. But this is the sort of thing you may see. So, mucosal bleeding, nose bleeds, mouth bleeds, bleeding with dental work. Normally a child with a bleeding disorder, you wiggle a tooth for 3 weeks, it's going to ooze for 3 weeks. And then when you pull it out, they usually do okay. If you go to a dentist and have a tooth extracted, that's probably going to bleed. A baby tooth will bleed less than a wisdom tooth. Makes sense. Mucosal bleeding, GI. Kidneys, not so much, but sometimes. Periods, a lot. And bruising is more classic of what we will see. Muscle bleeds, more than joint bleeds, but my cheerleaders are going to have joint bleeds, and my kids are playing soccer can have some impressive injuries. Yeah, we did that. Okay, so this is supposed to represent the portion of the clotting cascade as relates to the interaction of the endothelial wall, stimulating cytokine release, platelets, adherence to the Willebrand's factor, and bringing on the cascade. Lots of voodoo that we're still understanding, and these pictures are going to change. Okay, where's mine? Here it is. Okay, so this is soccer. So unfortunately, I don't understand why. People only wear shin guards to protect the tibia, but not to protect the calf, which is of course the soft place where bad things happen. So I see this unfortunately not that uncommon. And you're still as dead as you are now. Okay, so you've got rubor. It is warm. It is shiny, and that's not because it's clean. It's shiny because the skin is taut. Okay. Often you can sort of see the impact site with a different line than you'll see otherwise. As this begins to improve, and this is a supine picture, the discoloring will move down into the ankle. It's swelling into the ankle just as a function of gravity. Right now, this, if I saw him 5 minutes after he got kicked, it would be soft. If you see it in 2 hours and he's making a clot, it's going to be firm like wood. And as that breaks down, generally it's softer at the edges and remains firm in the center. When you have a very large soft tissue loss leading into the soft tissues, it can stay hard for a really long time. So if you don't mobilize that blood, they can say, oh yeah, I had a bruise that lasted 3 months. Did you touch it? No, I left it alone. So I have my same severe hemophilia kid who's fallen on his butt twice, and I still figure out why he's fallen on his butt twice, so that's another issue. Anyway, so he gets this hematoma, and it's the size of a softball. And the first time, because he hadn't done this before, we said, oh, lay down, put some ice on it, and be careful, and so he did, and he laid down, and it didn't really go away. We were given factor, we verified the factor levels were great, but he wasn't moving, and that softball went down to a baseball, but it was still right here, and it hurt to flex the hip, and he couldn't sit in the vehicle to go to school, and it was awful. We finally realized you got to mobilize it. You're going to, and to tell a 17-year-old that you got to massage your buttock, it really doesn't go over real well, because he don't want to do it himself. I'm like, it's not fair for your mother to massage your buttock. But if you've got a large amount of blood in the tissues, you've got to mobilize. So it's like, okay, you've done ice, now it's time to do heat and massage. Anyway, so you're going to have a large amount of blood. In a buttock, you can lose a couple pints. Baby, not so much, but then a baby's pretty small too. You can lose a fair amount of blood. You'd expect the CBC to be basically stable with this. If we had any skin breaks, it was a soccer injury after all. It becomes more red, crusty, heat, fever. I'm thinking cellulitis. Gotta have history, and then you gotta watch and see what it does afterwards. Okay, so officially, bum will runs, okay. In the old days, people used to do bleeding times, and it's still performed locally in some lab. So anyone ever heard about or know how they do a bleeding time? Ever seen that mess? Okay, so this is one of those archaic things. In Europe, they would do it on the earlobe, and then just do a prick like you do for a glucose finger stick. Do a prick, and then you take a piece of filter paper, or a coffee filter, doesn't really matter what, and you just touch it every 30 seconds and see how long it keeps bleeding. So in America, what we would do was you put on a tourniquet. The tourniquet is at 80 is where you're supposed to keep it, and then you do two little piercings. It's in a handheld lancet that you place on the forearm, and you'll see these patients, and they've got tracks up and down their arms of two little viper marks. And you make these, and then you, every 30 seconds. If you're doing a child, if the pressure's not even, if the hand is dependent, it will extend the test. If they're moving around, it will extend the test. It's not reliable, don't do it. You can have a normal bleeding time and have a very serious blood disorder. Hemophilia doesn't affect platelet function. You have 0 factor VIII and a normal bleeding time. If it's positive, did they move? Was the pressure too high? Was it dependent? It's not, don't do it, okay? But a lot of people, oh, did you do a bleeding? We don't do bleeding. Okay, there is no excuse, don't do it. Okay. The PT will be normal. The PTT might be mildly prolonged. It will not be wildly. It will not be 120. It might be 40 or 50. Okay. But it's not going to be wild crazy. Everything with a grain of salt. If you get fancy and you start drawing levels, you might get some abnormal levels. You just got off ORL. Who did somebody from outside come in to do your lecture? Or was it faculty?
The ones before faculty.
Jeannie Edmondstein was the PA, and Dr. Berryhill did more of the ear stuff.
Okay, good.
But
Okay,
outside
those people have not offended me. I got problems right now at OU where after when I came to work 27 and a half years ago, in the old days, it was great. In the old days, when one of our bleeding disorder patients would have a tonsillectomy, they were admitted post-op to the ORL service, and ORL would discharge them when it was appropriate. And then it's now, ORL is very good at controlling the pain, fluids, and whatever else in these patients. And even for a bleeding disorder patient, able to go home the next day. It is downright impressive. And we had 2 patients who were admitted 2 times within a week after the tonsillectomies, and ever since then they go to the hematology department after that procedure. Well, now that they realized that maybe they were being a little too nonchalant about bleeding disorders, they've started doing their own testing. So they do their PTs and PTTs, and they're sort of doing a family history because everyone comes in with nosebleeds invariably. And they have started drawing their von Willebrand panels. And if somebody comes back with a level, they feel free to make a diagnosis. So, at our institution, normal levels for factor VIII, and this varies slightly from lab to lab. It's 50 to 150%. Factor VIII is a true level from birth till death. Factor IXs are low at birth. Factor IXs are always low at birth. Every baby who has a factor IX level detected at birth is going to be low. And I bet your lab doesn't give you age-appropriate normals. Okay, just saying. If the baby is not 6 months old, it's going to be low. Anyway, so the von Willebrand's amount of protein, the von Willebrand's factor antigen or factor VIII antigen, normally, roughly 60 to 150, 50 to 150 depends on your lab. And then the function, which is the ristocetin cofactor, or the von Willebrand's factor activity is roughly 50 to 150. And so in the past 2 years, ORL and our group has started running their own panels, and if somebody comes back 59 and the normal 60, they diagnose it with von Willebrand's and then send us to fix. Okay. 1 lab test, 1 patient, without a history, without repeating it, does not make a diagnosis. And 59 out of 60 doesn't make von Willebrand's any more than a blood sugar of 111 makes someone diabetic, right? Okay. Don't do it. If you're not prepared to deal with the results, don't draw it. Okay, just everything with a grain of salt. So the best thing to do if you need to draw it is to draw it and then have someone who's used to dealing with those patients analyze it, okay? PT, PTT, you can pretty much say, yes, that's out of range, let's repeat it, oh, it's still out of range, could be real. Just saying, for this, we'll talk about. Okay, so, incomplete penetrance. Type 1, 80% of von Willebrand's patients, they just don't have enough. It works, they just don't have enough. So within a kindred, we may have an index patient who comes in, and we'll say that this one is a girl, okay? Her factor VIII level is normal, but she has a decreased amount of her von Willebrand's protein, which makes a 60 look pretty good considering she's only got 45% of her protein to bind to it. And then the function's a little bit low, not real low, but she's complaining of heavy periods. Okay, so in talking to the rest of the family, we find out, oh, her brother's got nosebleeds too, so let's check brother. So brother's level is 75, first factor VIII a little bit higher. The amount of the von Willebrand's protein is higher. And the function, it's a little bit higher than hers was, but the ratios between the two are still pretty similar. Looks like they have the same parents, maybe not the same gene. Oh, and she's blood type O and he's blood type A. Yeah, he's probably an AO, but anyway, he's got A. He's got higher levels. Yeah, but suspicious that those two have the same gene. This is the mama. Mama's doing fine, she's not having any problems. Oh, but by the way, she did have a hysterectomy when she was 23. Anybody having a hysterectomy before 40, something's wrong. Just saying, not normal. Okay, you always ought to get a better history of why any woman is having a, unless you burst her uterus with a C-section. It's usually because of heavy periods. Usually. Okay. So mama's got lower levels, but she's not complaining because we fixed her side of bleeding. Oh, you know, she had nosebleeds as a kid. She's fine now, she's not having periods anymore. But if she has her gallbladder out, she's not good enough for surgery. But she may not give you a history, because she's all better now. That's type 1. So generally, the factor VIII is fairly close to normal or slightly decreased, and the antigen risk to be a little down. The fun ones are when we start getting into type 2s. So type 2, it doesn't matter how much you have, it doesn't work right. So instead of having mildly decreased function, we've got a kid who shows up with a factor VIII of 10%. Oh my gosh, they've got hemophilia. Unless you were smart enough to draw a von Willebrand's panel, because you know, you're smart PAs, that you can only measure factor VIII if it's bound to von Willebrand's factor. So it doesn't matter what your factor VIII is unless you've also evaluated their von Willebrand's factor. And since factor VIII deficiency is 1 in 5,000 males, while von Willebrand's is 1 to 3% of the general population, unless the twin brother has diagnostic, genetic proved hemophilia, it's von Willebrand's until you prove it otherwise. Always, always, always check your von Willebrand's levels. Okay? So a type 1, in this one, what does the defect seem to be in von Willebrand's protein? What portion of its 3 functions is not working? The factor VIII is low. We're not binding properly. So the factor VIII is disproportionately lower than the von Willebrand's factor. It's not adhering. If this had been platelet adherence, the levels aren't that impressive, but you've got a lot of bleeding and there's some separate issues we'll be doing. Or you may end up with levels where you're making some protein, it may not be totally normal range, but your function is very low. All 3 of these levels need to be drawn at the same time and sent to the same reference lab. So at university, we can do a plain factor VIII all by ourselves, but if we're going to do a von Willebrand's panel, we've got to send it out. So some people who don't understand how the system works will say, gosh, I'm going to order a factor 8 and have it run on campus, and I'm going to mail these two out. Well, at a different reference lab, your standards are going to be different. You can't compare the three ratios together if they're not running the same facility. They all need to be in the same facility to make sure that that's a valid situation. When we're going to treat these patients, if I've got a factor 8 deficient patient, and they're truly just factor 8 deficient, I will give them factor 8 to raise their level up. If I have a von Willebrand disorder patient, depending on what their defect is, I may need to give them normal von Willebrand concentrate infusion, because even if I double this level from another route we'll talk about in a moment, if I double the level, this goes up to 10 or 15%, doesn't matter how much of protein I have, it doesn't work. Okay. Whereas if I just have type 1 decrease amounts, it works fine, and I can manipulate their system to raise the levels, we'll do fine without needing to give an IV infusion. Okay, let's see what I can do this time. Yes. Okay, but you don't need to be making these sort of fancy diagnoses in your lab. Only you think about it, oh, something's wrong, I'll do a basic screening, doesn't look quite right, significant family history, personal living history, I'm going to refer this patient somewhere where the answers are up to date and changing. Yeah, okay, there's my pretty leg. Yep. Okay, so 1/3 of the general population. They recently changed, 4 years, 3 years, recently changed the diagnosis so that they want your levels to be less than 30% to get the full diagnosis. Incomplete penetrance. So if you're type O and your level is 40% and your hemoglobin is running around 9 from periods of the last 2 weeks, you have features of von Willebrand's, and you'll get the diagnosis. Type 3s, where it doesn't adhere and the factor 8's running 10%, when you check their von Willebrand's levels, they will be disproportionately low to the factor 8 level. It just doesn't work. Doesn't work. And so we will always have to be careful with a new diagnosis, no family history of factor 8 deficiency, to check and make sure it's not actually one of the very rare type 3 von Willebrand's, because the treatment changes and it will make a big difference. Okey-dokey. We talked about this. Wonderful. Wonderful. Yep. Yep. Very picky. Don't need to worry about that, but just know there are lots of reasons. Oh, this is my best one. Okay, so this happens to be a type 2 teenager, had a pimple, so he squeezed it. And he didn't come in to see us for about 4 weeks. And he, you know, you can't hide this. You really can't. So he had a hematoma. It's bigger than a mothball. I mean, so the clot is about 2/3 of the size of the underlying hematoma. So we gave him factor replacement, warm compresses, gentle massage, and an anti-fibrinolytic while we worked on that. We're going to talk about that secret here in a second. Yes, okay. We're doing good. All right, platelet disorders. Moving on. So we talked about the factor 8, which attaches to von Willebrand's factor. And we talked about the role of von Willebrand's factor in helping platelets aggregate and migrate to a disorder. Platelet disorders are genetically about 1 to 3% of the general population, more often in African Americans. But you can get a lot of fake and transient platelet dysfunctions from people taking special medicines. The most common abnormality is a mild aspirin-like defect. I'm still not clear, we don't have genetics where we can draw and see if this is real or if people are surreptitiously or accidentally getting a hold of something. And it doesn't take much Pepto-Bismol to inactivate your platelets. Okay, lifespan of a platelet is what?
3 days?
Yeah, right. And aspirin stays in your system, aspirin kills platelets, right? That's why you take aspirin, so you don't have a heart attack, right? So if you're taking ibuprofen and naproxen, it inactivates your platelets for a while, and it doesn't take much to do that, right? So platelets, first level defense, 4 hours, superficial soft tissue bleeding, usually in trauma areas, it's not generally spontaneous. There are several different kinds of platelet disorders. There again, they don't aggregate, they don't contain the necessary granules, they don't secrete the right things. We have gene testing for some very specific abnormalities. And this is where we go back to our bases again, yes, and we will use this later on when we talk about periods. Okay, so the top of the clot is the fibrin, right, okay. So the best drug that's now come into, back into the country and is available as a generic at most corner drugstores is an anti-fibrinolytic. Tranexamic acid, this one's worth knowing. Tranexamic, oh, come on, help me. Yeah. Tranexamic acid, okay. Anti-fibrinolytic keeps the fibrin net in place while the underlying tissue heals. Obviously, it might take a little bit longer if you don't have a great clotting system underneath, but very helpful with platelet disorders. Platelet transfusions are helpful, but when you infuse someone else's platelets, you can form platelet antibodies and thus decrease your response subsequently. For the most severe platelet disorders, they may need bone marrow transplant in the future. You don't want them to already have antibodies to infuse blood products. Okay. The other thing that you can do is, you must not touch, is to use extrinsic pathway. Factor 7 works with tissue factor to help accelerate clotting, bypassing the system. You can give that. Only works with fresh areas, which you can try that. So this is going to be new in our armamentarium. Very, very expensive, IV only. Amicar is the old-fashioned product. Tranexamic acid now has come to market that we can use for this situation. There again, especially in older population, if you're providing an anti-fibrinolytic to someone who's prothrombotic, you're increasing the risk of stroke and heart attack. So for my 70, okay, I have one picture. Anyway, for my normal 70-year-old who's having a tooth pulled, I won't use it because the risk of clotting is too high. I have a little old lady right now who has angiodysplasia in her GI tract. She's getting transfused red blood cells twice a week. She is transfusion dependent. Right now, her risk of bleeding to death is fairly high, so she's getting a baby dose of an antifibrinolytic with full understanding she may have a heart attack and clot, but right now she doesn't want to go get transfused every 2 days. Anyway, another story. Platelet disorders are very hard to diagnose unless they have very dramatic effects. It's going to take a lot. The local testing that you have available in your lab is going to be a PF, platelet function analyzer. It's a visual evaluation of aggregation. It's highly unreliable. If it's a positive test, you still have to do live platelet function test. If it's negative, it doesn't rule out open disorder. So we're not real fond of those. This would be an excessive bleeding. This is, if you can see an antecubital area, and you can see puncture sites, repeated puncture sites from venous access attempt. Yeah, 5 minutes pressure, you made a hole. Right? Other common things that we will see with platelets. Oh, come on, help me out here. Here's the pretty picture. I know where I put it. There we go, pretty picture. Okay, so Phenylketonuria purpura. Do they have a history of a viral illness? Some of my kids who had mono. So, yes, he had von Willebrand's disease, but he also had mono, and then he comes out with this rash. He had what's normal. He had a post-viral exam. So, it's usually in young people, they're saying technically 2 to 11 years old. Obviously, kids who have mono are a little bit older than that. It's usually after vaccination or a viral illness. Goes away by himself. He was one of those special people who not only had the purpura with it, but he also had hematuria, freaked his mom out. Anybody comes in complaining of hematuria, there's bright hematuria, which looks like red Kool-Aid, and there's old blood that looks like tea. Gotta distinguish. And if the blood has been sitting in the tubules or ureters for a while, they may have black strings. It's just been sitting there, okay. It's categorized. Hematuria, great, bright, old, ought to look different first thing in the morning than it does in the day. Yeah, the normal rash. It can, this sort of thing may also occur as a hypersensitive reaction. And so there you can kind of see where's the location, what's your personal illness. No. Yep, okay. There we go, vitamin K deficiency. More help. Okay, so if you draw a lab and things are really, really weird, the PT and PTT are both long, draw it again. If it's still both, no touching. No, really, no touching. Yep. Okay, if the PTT and PTT are both prolonged, you've got a CBC, are the platelet counts normal? If you think you've got a concern and you're getting an automated CBC, platelets look low, you need to get a manual spear because the machine is not smart enough to tell you whether there are truly few platelets or whether the platelets are aggregated so it counts as a lower number. So if you have a concern, get a manual spear and make sure what's the actual platelet count. Okay. And you ought to be checking to see when you have the situation come up, are they clotting? Is that one reason both PT and PTT are high? You're ruling out DIC, get a fibrin split product. At your institution, sometimes it will be fibrin split products and sometimes it will be fibrin degradation products, slightly different tests. Your institution will tell you what you're allowed to drop. Yeah. And the other fun thing with vitamin K deficiency is if you start checking their factor levels, everything's low. It's bizarre. And when you will most commonly see this is going to be in babies a couple days after birth. They're starting to ooze weird places. They've got a scalp hematoma post-delivery. They're bleeding from their circ. They're bleeding from their heel sticks. They are just kind of oozing crazy. May have intracranial hemorrhage, but they are oozing in everything looks totally out of whack. But they still got normal CBC. I mean, they're losing some blood. They're getting a little anemic, but they've got all the parts of the components that they should have. The endogenous vitamin K levels drop a few days after birth. That's why you're supposed to get your vitamin K injection here. So if you've got home deliveries, you've got midwife delivery, and they don't come back in to get their state screening and get their vitamin K, you'll see this. You can see it in adults with particularly very ill adults in the hospital, no GI intake, especially if they're on antibiotics, especially cephalosporins, can deplete the stores. Chronic malabsorption syndromes, you've got GI issues that are not absorbing, you'll see this. These are sick people and they're pretty scary. And so what you want to do is make sure that what you're dealing with is not actually DIC. Yeah. Okay, DIC. So in DIC, you're bleeding and clotting at the same time, your platelets are low. There again, get a smear, make sure it's really the number is low and not just that they're aggregating, you just count them right. Fibrinogen's another thing you'll be checking, either fibrin split products or fibrin degradation will be decreased. Yes, the PTT are long. The red blood cells are broken. It's part of the cascading effect is that you're chewing up everything. And there again, lots of factor levels are low. Kind of a scary situation. We've got time. Okay, questions at this point before you go into fun things like periods and nosebleeds? Okay. All right, so practical things. Very good. All right, so favorite thing that I like to talk about. We'll do nosebleeds first because they're fairly short. So, what are your most common sites, common causes of nosebleeds? And the finger. Right, okay. So you've got your Kesselbach plexus right here. It just happens to be at the point where when you wiggle your nose, you're pulling blood vessels. In the winter, when air is dry, if your lips are chapped, your nose is chapped, right? And it doesn't take much wrinkling to pull those blood vessels apart and let them squirt. From a bleeding disorder standpoint, I always want to know if you're having nosebleeds, is it one side or both sides? Is it only during the day with activity? Is it when it's hot outside? Are you having allergy symptoms where you're congested, you're blowing your nose, everything's inflamed anyway? Or are you waking up at night with nosebleeds, which, other than a kid with fingers in their orifices anyway, it's always a little bit more suspicious. So, since most of the nosebleeds are lower, how do they tell you to treat your nosebleeds?
Squeeze.
Pressure.
Yeah.
You can.
And where do you hold your nose?
Down.
Right, the soft part, you're not holding the bones, you're not squashing anything, you hold the soft part. If it's bleeding from both sides, otherwise if the side that's bleeding, hold. 5 minutes pressure, right, 5 minutes pressure, give the blood vessels a chance to stop. We recommend leaning forward, because if you're, I feel like, faint, and I'm swallowing blood, I'm gonna throw up, you're gonna Valsalva, you leave that, right? Lean forward, after 5 minutes, blow out the loose clot. Looks like a piece of jelly, right? Okay, all that's doing is holding the blood vessels open. It's not actually forming an effective clot. Blow it out. If it starts rebleeding, hold pressure again, do the same process, blow it out. If it stopped at that point, you may be done, or you can use a nasal decongestant. Afrin Gus and Afrin generic is fine to shrink the blood vessels further. Can't use it 1-3 times a day. You need to keep it moist. Some of the oral folks like coconut oil. They say Vaseline too occlusive, antibiotic ointment, anything to keep it moist. Whatever you do to keep it moist. Increase humidity in the household, basics, drink fluids, whatever else, keep your fingers out. Okay. And that will help. If you cauterize, that fixes this. When that scab comes off, they may bleed again because you ripped open the bed. If it stays there, it might work for a while. It can work permanently. If you've got a bleeding disorder, you can still have abnormal vasculature, and that can be helpful, but it may come back later. Things are basic. Allergies, you got to treat the underlying allergies. Best word knowledge is going to be on periods. 50% of your patients will probably be female. Chances are. During their lifetime, 50% of the females will be having periods, also important. Periods happen when your estrogen levels fall. That's when your factor levels are lowest. So the best time if you're working up a bleeding disorder is going to be during the menses when their level is lowest. One of the things people will do to treat heavy periods is to put them on birth control. Birth control raises your hormone levels. It'll raise your factor levels too, so it'll kind of mask or cure. So we have arguments in the office as to how high that might actually raise your levels, whether it would be good enough to move it. That was our normal level. So if I had mama who was 60, 35, and 35, if that would raise her closer to 75, 55, 45. Maybe enough to raise her quite a bit, at least control her periods. So the other thing that we can do for heavy periods is to use an anti-fibrinolytic. So tranexaminase acid has come back to market in a 5-day pill pack, 2 tablets, 3 times a day, starting the first day of your cycle, to protect the uterine lining while you finish your cycle. It's now one of the #1 drugs in Scandinavia for people who don't have a bleeding disorder. It came back to market, used to be for hemophilia bleeding. It's come back to market for heavy periods. So when I have my young men are having the wisdom teeth out, and I send them to the pharmacy to pick up their 5-10-day pack, and the pharmacist says, insurance will pay for it because you're a male. It's an anti-fibrinolytic. 30 years ago, we used ring for it. Anyway, it's wonderful as an adjuvant. So when you're evaluating periods, you need to get a specific history. When did menstruation start? Were periods irregular initially? Were they heavy initially? If they've got a family history of a bleeding disorder, they don't know what normal is. Okay, what's the normal length of a period? Yes, a week. If they're on the pill, they're thinking 3 to 5 days. A week is your normal outlier bounds. Okay, so period should be less than a week. Now, when someone is just starting, their hormones are not regulated. They may be long, they may be short. It'll be different this month, and then 45 days later, they start their second period. It'll be different. So it may take a while to get situated. when women, female people, are using a product to control and contain their flow, they should not be soaking through things more often, every 3-4 hours on the worst few days. Okay. It is inappropriate for women to be needing an overnight pad during the day at school. They should not be soaking through an overnight pad between classes at school. That's not appropriate. Okay. People should not have to stay home from work or school because they're having to change every 30 minutes. Now, some people are going to want to change because it feels damp and they got to get out of there. Okay, that's not, and that's why you need to quantify. So the definition of menorrhagia is more than 80 mils of fluid. 80 mils is not much. But like anything else, like having a nosebleed and you're watching it drip, it doesn't make much blood to look like a lot of volume. 80 mils is the normal top for your period. If you're having more than that, you've got issues. And the British actually did those studies where they actually had people bring product in and they would weigh it to measure this. Okay. Hemoglobin should not drop down to 7 from a period. You also should not be anemic from nosebleeds. So if anyone tells you, oh, I've got heavy nosebleeds, and they're getting admitted for it, they're anemic, they need iron because of their nosebleeds, that's a bleeding disorder, don't do them otherwise. Okay, you don't get anemic from nosebleeds, out of proportion bleeding. It is not uncommon for young ladies with bleeding disorders to be admitted with their first cycle and a hemoglobin of 4. And we'll talk about hemophilic carriers while we're talking about periods here in a second. All right. So if you've got a young lady who comes in complaining of heavy periods, how often is she soaking through? Is she using the appropriate product? What's she taking for a period? Midol and Pamprin are the most common brands of period pills that people will take. There's 6 formulations of each kind. There are different combinations of diuretics, antispasmodics, there's caffeine, they've got aspirin, they've got ibuprofen and naproxen. They've got to read the ingredients to see what they're taking that might be making the flow heavier instead of better. Okay, because if they're taking ibuprofen every 4 hours for cramps, they're probably going to have heavier flow. You've got to check and see. Parents of teenagers are allergic to the idea of their children taking birth control. And if it needs to be done, we prefer to call it hormone regulation than birth control, because they don't like the idea of their 11-year-olds on birth control. Okay, so the first layer of things you can do for any child with a bleeding disorder who's having problems with their cycle is an anti-fibrinolytic. It's non-hormonal, it's for 5 days, you don't really have to remember to take it on schedule. Okay. If they've got a bleeding disorder, we can talk about bleeding disorder issues that will assist with that. The third line, when you get to that point, is taking hormones to increase their hormone levels. The problem with taking hormones as a teenager is you have to take it at the same time every day. They can't brush their teeth at the same time every day. It's very, very difficult. And if you miss, and for some ladies, you miss by a couple hours, you're going to break through bleeding. That's significant. So they may not be able to take it regularly. If they're not able to control the length of their bleeding and break through bleeding on a 21-day pill pack, it is biologically impossible to expect them to be able to do that on a 3-month pack. If you can get them regulated on a 21-day pill pack, then they may be able to graduate to a 3-month, but it's not appropriate or a reasonable expectation to think that, oh, it didn't work taking it for 21 days in a row, I'll just put them on. Okay. Because at least if you're taking it for 21 days in a row, you know when your next period is going to be. And if you're on a 3-month pill pack, you never know when it's going to be. And if you miss a pill, it's not just spotting, it's going to be a catastrophic breakthrough period. So don't do it. It's just not going to work. For some, they can use the Provera. Excuse me, that's not the right one. Wash my mouth, that was it. What, Depo-Provera. There we go, much better. Depo-Provera, which eventually will control their periods for some people they won't. For young ladies that are not able to tolerate antifibrinolytics, most can, some are very prone to nausea. They can't remember to take a pill. They can graduate to the IUD. There's now an IUD, the right size for teens. It's no longer a third-line indication. A progesterone supreme. The Mirena is the full size for adults. No longer contraindicated for teenagers. It's nothing to do. Okay, so we talked about hemophilia carriers, let's go back to those because we were not stuck with that. Okay, so, X-linked inheritance. You got a mom and a dad. There again, the answers have changed. The smarter we get, the more questions we have. Okay, so X-linked inheritance. And, yeah, you're just gonna have to use imagination. Okay, so men have an X and a Y chromosome. The factor VIII and factor IX genes are on the tail of the X chromosome. Guys don't have it, they only have one copy. And since they determine the sex, the gender of the offspring, if they donate their Y, it's an unaffected male, unaffected male, unaffected male, can't pass it on in the story. If they pass on their X chromosome, their effective X chromosome, their wife can only secrete an X, that's a carrier, right? She's the only choice she's got. She's got dad's gene variant, and she's got mom that technically works. The body is not smart enough to pay 50-50 attention to the two genes in the sex-linked chromosomes. X-linked skewing. The body, we don't understand why, will pay a variable amount of attention to genes. So, although you may have one gene variant, the males have the same gene in the family, right? So if I have a gentleman who's got severe factor VIII deficiency, his grandson's got severe factor VIII deficiency, his uncle's got severe factor VIII deficiency. They've got the same gene copy, there's only one copy, it's the same gene in male. But women have got two genes. But depending on how the body skews, lionizes, dad's severe, she can range anywhere from 0% to 150%, depending on which gene the body pays attention to in which perspective. So if she's not totally skewed and her level's running 30%, she's not going to have spontaneous joint bleeds, but she'll bleed like stuck pig during her period. She's got 30%. If it was a male whose factor level was 30%, he's playing football and he's going to have a hard knock and he'll have some bleeds. She's bleeding every month. But the women may not report this because they're not having joint bleeds, and they feel sorry for their little brothers with joint bleeds. So they don't say, oh, I've got heavy periods, because grandma had heavy periods too. She thinks it's normal. Or when this young lady has children, hopefully not with somebody from Camp West hemophilia, she meets a nice young gentleman who doesn't have bleeding disorders. She's got a 50% chance of sharing this X chromosome. Her daughter has this X chromosome. Her daughter's level may be anywhere from 0 to 150, 200%. Doesn't matter what mama's response was, the skewing is different in each individual. And so this family doesn't know what normal periods are because they're not normal. Yeah. And so the old literature said that females, even with the abnormal gene, don't bleed. It's not true. Their factor levels are their factor levels. Now, her level will vary during her cycle, up and down. Factor IX levels do not rise during pregnancy. Von Willebrand factor VIII levels will rise during pregnancy. They drop down within 24 hours to a week postpartum. They have an increased risk of postpartum hemorrhage up to 6 weeks postpartum. So we'll put them on fibrinolytic, antifibrinolytic prophylaxis postpartum. Now, if her level doesn't rise above 70% before delivery, she'll get factor to make it safe for her to have epidural. She's going to go for a C-section, she's going to be better than 80%. And so we've still got a new group of physicians out there who don't understand that women bleed and don't realize, oh, well, she was 30%, she wasn't bleeding that much. I mean, once a month, because they all bleed once a month. May not remember you've got to cover her during delivery and afterwards. So that's kind of an underserved population that you have to identify. We just had a factor IX, a young lady with factor IX level of 40%. Factor IX is normally 60 to 150%. Her level was 40%. We've checked everything else, the factor IX's the only thing is low, we don't have any identified males in her family. So right now, we can't do genetic testing on her to figure out if she's truly a factor IX carrier or something else is going on. In factor VIII deficiency, the severe deficiency, 1% or less, is most commonly caused by a single inversion mutation. Very cheap and easy to do that testing. For milds, more than 5%. Lot of variation, 2 to 5%, fair number of mutations. But pretty easy to check. You send it off and we'll get results back. With factor IX, the mutation may be unique to the kindred, which is why we need a male with factor IX deficiency in our family. We're going to have a brother come in and check him to check and see if she has a genetic mutation. With von Willebrand's, we have mutations for some of the type 2 qualitative defects, but not for the type 1s. Part of the problem with that is Scandinavia, where they've got lots of the patients. They did random genetics on a number of patients to find any mutations in that von Willebrand areas. And they had a number of people who had positive mutations, but no symptoms. So it's not predictive, and we're not going to pursue it at this point when there's so many mutations. But yes, when with bleeding disorders bleed, and they need to be working accordingly. Symptomatic carriers, you may have to elicit the family history of a bleeding disorder to identify this person at risk of being a carrier. So any male with hemophilia, daughter is a carrier. Is a carrier, unless they've had in vitro fertilization or something else. Always is a carrier. Her sibling, brother, cannot have it. And this is what doesn't need to be checked. When she has children, if her family mutation is known, her children at birth, son would have cord blood drawn for factor deficiency? Yes or no answer right there. Her daughters could have cord blood tested for genetics at birth. For von Willebrand's patients, if they are having offspring, we'll draw cord blood for the von Willebrand's panel at birth. They may be low, or we can identify from their ratios at birth that they're already at risk. And can follow them preemptively from that point. Questions? Yes.
What did you say the first line of treatment was for a woman who's on her period and she's got a bleeding disorder? Was that anti?
I'd still use the anti-benzodiazepines. It's non-hormonal. Use it for 5 days. So the other thing that you can do to raise factor levels, factor VIII and von Willebrand's factor, is to use your vasopressin, which is DDAVP desmopressin. Your body's response, the bear is going to chase me. So you recruit your clotting factors into the bloodstream. So your von Willebrand's factor, your factor VIII float from the endogenous stores into the bloodstream. You have a shunting to the core of your blood. You have urinary retention because you don't have time to stop to the bathroom, right? Bear's chasing you. That will last about 8 to 12 hours half-life. So DDAVP desmopressin, we'll see that advertised for childhood bedwetting. Doesn't take much to make you retain fluid. It takes a lot to make your factor levels go up. It is an unpredictable response. So you know lots of people who just don't get stressed out with the hang gliding, bungee jumping, just because they're only phasing, right? Me, I don't even have to stand in line and know it goes up. So you have to test a person to see if they respond to that medication and raise your factor levels adequately. That might be a treatment that we can use for them. It comes as a high potency nasal spray, probably, $205 nasal spray. It's not on the shelf at Walmart. Instead, and for my mild hemophilia males, maybe able to use that. But there again, if your level's 5%, it goes up, gosh, 300-fold, maybe you can use it. But if it goes 5% to 15%, it may be good. Good question. What else? So if these bleeding disorder patients are 1 to 3% of the general population, you're going to see them. And it doesn't matter whether you're working in cardiology or diabetes or primary care, they'll be there on top of anything else you've got. My oldest patient is 92. He just had a second hip replacement. He got diagnosed just before he had his first hip replacement, he'd always had some bleeding issues, but they assumed that was because he was a cowboy in competitive rodeo. That wasn't his issue, he had a mild back. No, but they're living older and it's getting more complicated. So we did open heart this summer on a moderate factor VIII. We done several open hearts on vulnerable runs. I think most of the severe factor VIII and factor IXs with bad congenital heart disease probably die at the initial surgery. Don't see many of those, but they're living to normal age and they're having little things going on. You'll see them, it'll come up. So the basic labs start with the CBC, PT, PPT. Those are suspicious, you've got a good family history. You can draw a von Willebrand's panel. It looks weird, make a call. If you've got somebody in the family clearly diagnosed, you can work with that, but call somebody else and help you out with it. You gotta know everything in goodness that they're taking. A lot of people doing surreptitious stuff on the side because they heard it would be a good idea to take it. Or they're gonna double up on the fish oil because they heard it would be good. Anything that says it's good for circulation will affect your platelets. You're doing extra fish oil, they're doing garlic capsules, it's going to affect your platelets. Obviously that's your first line of clotting, right? It's very easy to mess with that. You'll see that. Get your CBC with a manual smear. Look at it, make sure it's not screwed up. Like I said, one lab does not make the diagnosis. Anemia out of proportion to the symptoms. A little suspicion. Bad nosebleeds if they last for 2 hours. Now some people say they last for 2 hours means that if they blow their nose every 10 minutes there's still blood on the tissue. That is not a nosebleed. Okay, that's a if you're dripping over the sink, I can call it a nosebleed. Right? Everything's in proportion. You gotta get them to describe it to you clearly. You need a really good family history. Family history is better than that. Yeah. All right, salad bowl clotting. Right? It all works together. And it will affect every other patient that you see. Always ask. And the answers do change. Other source of estrogen, body fat. So I've got some carriers. They were so ticked. I've got a carrier who's, I know her levels were in the 20s when she was very young. They're in the 60s now, but she's also 3 times normal size. She just didn't understand how she got better. And I can't exactly say, gosh, she could lose 150 pounds, and you could be a patient again. Yeah, so it does go up. They also go up a little bit with age. So answers change. So a lot of people say, yeah, I was diagnosed 40 years ago. That's great, the answers change. And so the diagnostic testing has changed. And so it may need to be updated. We have to update all the time to see if things have changed. The treatments are pretty specific. Factor replacement, don't be different with that. Okay? If you're talking $1,000 a dose, you don't want to be playing with that. Call somebody who knows how to spell it. ORLs, don't make their own diagnosis and then tell somebody else to fix it. It was fun. I'm sure I'll see you in the hospital if things come up. Ask. Obviously, there aren't any stupid questions. If you don't ask, you won't know. We tell the families the same way. What's in the literature is going to be, for the most part, outdated. The horror stories are what get printed. The best cases, people dying from a finger cut, that's what gets in the literature. That's not what's classic. Our kids are currently instructed to go out and play for an hour or 2 a day. We don't recommend football. I wouldn't let my kid play football. You're going to live to be 92, you got to take care of yourself now. So the same preventive health measures everyone else needs to take, they need to take. So they're out playing sports, they're going to be on your kid's baseball team. They shouldn't be on your kid's football team. But they're going to get out and doing everything else. They're in the workplace, like everybody else. You're going to see these folks as long as we take care of them now and we identify the ones that haven't been identified. Y'all good?
Thank you.
Okay, I'll see you in a minute.